As we speak today with our very distinguished guests, Dr. Nandita Palshetkar and Dr. Rishikesh Pai, this is Dr. Hema Divakar bringing to you this program on something new, something innovative in the anemia space. As we speak here today, our parent organization FOXI is also running a whole day of anemia conclave, and a leader here, a leader there. We are going to be everywhere, just like how anemia is everywhere. And that's the sad thing, ladies and gentlemen. An artist, Asian Research and Training Institute of Skill Transfer, put in some very naive original work in the space of anemia in rural Karnataka with the use of parental iron, which went places later and changed the anemia policy at the Ministry of Maternal Health and Family Welfare. The guests today here with us are none other than stalwarts, the evergreen and ever-shining Nandita Palshetkar, whose focus of work is fertility, but the organizational position of the FOXI president and many other prestigious positions that he has held. It has given her great insights right from the most important thing of the respectful maternity care in the project Manyata, which she speaks so highly on a variety of platforms. And I must say, the vision is all encompassing around that. Her subject is no matter at all. Her subject is the girls and women in this great country and Asia, and he is here to make a difference. The next guest is Dr. Rishikesh Pai. I really admire him for his mega ideas. She never thinks small. It's always on a very big scale. And dear friends, that's the scale this country needs. Because when we say 100 centers, 1,000 centers, it means a lot to the outside world, because the population in UK is just like the population in Karnataka, one state, for example. So they think that 100 or 1,000 is a great number. But Rishikesh knows 30 million deliveries here. And it is like a continuum and never stopping. So population explosion is something that we need to get a handle on. And his illustrious father, Dr. Datta Pai, who has initiated many innovative projects for the country, the genes and the legacy is moving on. When Rishi steps into the prestigious post of the president of FOXI, what is it that he may plan to do on a mega scale? Or never ever again we should be talking on the forums on anemia control. It should be a non-issue. That is how Nandita and Rishi are looking into this. So in conversation with these two great leaders who are in their own way, age no bar, they are my inspiration too, because constantly being with positive people like them has never made me step back, and all initiative with immense support and cooperation. It's just going on and on and on. Artist is our organization, as I said, Asian Research and Training Institute for Skill Transfer. The art of artist. Assisted reproductive technology is art to Nandita and Rishikesh, but the art of artist in our organization is A for advocacy, R for research, and T for training and capacity building. It's a mega vision, taking the cue from Rishikesh, but for 30 million deliveries, we need 1 million healthcare providers, the frontliners. The mission is to train and build the capacity of that 1 million. And let's move forward with the talk that I'm going to be encapsulating around oral liposomal iron. Liposome is something to do with encapsulation. So the anemia is getting into a package of the liposomal iron, about which I will tell you a few minutes later. First, conversation with Dr. Pai and Pal Shetkar, the persistent efforts by the PPP. P for persistence, P for Pal Shetkar, and P for Pai. That is how that gang has got together, because they know that I'm a persistent pest. I will never leave them alone for the things that we want to do, because we truly believe that together we can. And so, Nandita, why are we always speaking about every 1 out of 3 pregnant women is having anemia? 20% of maternal deaths are caused by anemia. Oh my God. 20% of maternal deaths is caused by anemia. Why can't we do something about it, Nandita, to save lives? What are your thoughts on that?
I think, Hema, basically our Indian diet is the culprit. We eat a very carb-rich diet, which is deficient in micronutrients and macronutrients. And that's where the problem starts. And also in our country, I think it all stems from gender discrimination, gender inequality.
Absolutely.
I think the girl child is not given that much. So I think it begins from childhood, adolescent, and these adolescents become deficient mothers and they pass it on to their children. So I think we need to really... I personally feel, as of President Foxy, when I was there, we did a lot of programs on anemia. I mean, we evaluated, we ran programs to evaluate hemoglobin all across the country. But now WHO has come up with that ferritin is actually the ideal way to evaluate the anemia, and that would give us a more accurate reading. But personally, I feel that advocacy, as you said, your vision of ART, I think the artist vision is very important. The advocacy is really, really important, because informing the people, telling them what they need to do. And especially, now mothers, because we all know that the adult disease, the beginning is in the womb, and we really need to take care of them. So yes, the urban population is the one which is educated, and you can talk to them and give them supplements and other things. But the government of India has actually worked very hard in this particular segment, and they have done a lot of initiatives like distributed oral iron. Then, postpartum, as soon as the mothers deliver, you give them an injection of iron to bring up their anemia. And the latest thing is Poshan. I think it's very, very important project of the government of India, which talks about micronutrients also along with the iron. And I think that's very, very important, because all the complications of pregnancy, as you're talking about maternal death, they are taken care by this combination of micronutrients with iron and folic acid. So I think that's something that's really, really important.
Very, very well put, Nandita, because as I said, beyond the technical know-how, it is also social factors, especially the gender inequality, because the women in the house eats the least and eats last. So these angles also have to be looked into in our leadership position, so that in a wholesome manner, we will get this initiative moving so that it reaches its meaningful end. Thank you very much for those very insightful inputs. Rishikesh, population explosion has been something, which is, as I said, it's a Khandani issue with respect to you. We need things in mega scale because we are just so many people in the country. And also, you brought in the thoughts just before we started this program. Hey, it's not only the iron deficiency anemia. There is sickle cell, there is thalassemia. There are other groups which are, nobody really knows. So what are your thoughts on this? What do you want to do as you are on your journey to the...
So, Hema, I feel that thanks for calling me on this program. It's a very important part, anemia hatao kind of regime, and the government already launched the Anemia Mukt Bharat Abhiyan and the Poshan Abhiyan. So these two Abhiyans are already there. But the Abhiyans are there, but how do you reach it? Because whatever we do, there is an inequity between what is available and what is the demand. So demand is all the time growing, and one of the biggest problems is the population. So on a macro scale, if you look at the country, whatever we create, it is falling short. It is a Malthusian theory of inequity. And this falling short, the problem is everyone, all the political, because the political dispensation is very important. Dispensation is important, but all the political parties want to do family planning, but they don't want to do it actually overtly because they are worried about their own status among the population. However, the population is mentally quite advanced now to accept the family planning measures, but that is why the role of the advocacy and implementation of family planning should be with an NGO like the Federation. Foxy is a neutral NGO which can implement this thought process of the government and the opposition without getting into any controversy. And so that is
such a rich human and intellectual resource.
Right. So this is important. So our policy has to be, unfortunately, what happened during my father's days, the main policy was family planning. So unfortunately, research and development in curative medicine shifted our division from prevention to cure. Curative medicine is more appealing to all our members, right? You do endoscopic surgery, you are more happy. You do robotic surgery, you do IVF, you are more happy. But because of that shift from the goal, that 40 years of shift into curative medicine has actually weakened our medical profession as far as the public health is concerned. And that need so we need to have the new future is to go hand in hand with the prevention and the cure. That has to be together. We have to work together and at the same time also factor population. So this is the first thing. The second problem I personally feel is that now there is something called advocacy, but there's a gap between implementation and that what you want to do, right? Yeah. And what is that gap has got two major hurdles. One is the inaccessibility. So we have got two types of population which are running in parallel. One is the urban-rural divide and another is the private and public hospital divide. Public hospitals are being, in the urban areas, are being looked after well. So if there is a person who gets admitted, hemoglobin is done and she's tested. So, and they are giving IV or oral and they are supplementing with potion, blah, 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 etc. So they are taken care of. Private people also in urban are going themselves and getting admitted. What about the COVID infection brought to the fore a hidden India, which we were not aware of? Did we know that there were 20-30 lakh people working like migrant workers in the city of Mumbai? We were totally unaware of this kind of hidden population. And this population is the population. How are we going to reach them? So this is the challenge. So how are we going to reach this migrant worker population, which is not only in the urban areas, but also, of course, they come from the rural areas. And this is the challenge which has to be utilized through the network of ASHA workers and the new weapon that we have now. We see COVID has weaponized us. What is the weapon that COVID has given us? It has given us the insight that digitalization is a major power which we have. And if that digitalization power is wielded by us well, we can implement policy in a very aggressive and effective fashion. For example, a simple thing, like whenever you pick up the phone, what happens? The recording comes, blah, 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 COVID, don't wash your hand. We don't listen to it also. But if suppose instead of that, we have a recording. So every Indian has a recording in his mobile phone. But at that recording should not be anemia specific. It should be holistic. All the healthcare has to be concentrated in those recordings. So every day of the week, the recording can be different and you can give different messaging to the person who is talking on the phone before it starts talking. Just a 30-second messaging system, if we can incorporate, it will create a major revolution in the way you implement policy in our country.
Absolutely. 2 points, very, very well taken, Dr. Rishikesh. One is about they're all around us, these migrant workers, but we were not in sync with the reality. Even in the urban, we have an opportunity to address them. And that has rightly been brought forth very brilliantly. And also, as it is, we have examples of innovative digital methods of reaching people, which again, the COVID, as you said, has brought to light. There are many such opportunities, not only for advocacy, but also to get the data of the non-invasive hemoglobin test, like the pulse oximeter now almost every family is having. That way the hemoglobinometers anywhere and everywhere can be made available and they'll go for a test, and then it is divided into traffic zones. If it is green, that means you don't have to worry. If it is amber, you have to be on the alert. If it's red, you have to see your doctor. That kind of stratification from anywhere and everywhere. And we are all here, champions from the organization who is already ready to serve. So both of you have said that we need to connect and collaborate with the government, because the leadership position and the organization of Foxy itself give us the insights that public, private, anywhere, girls and women have to get the necessary care. And in line with the concerted efforts with the government, Foxy has of course stepped in for Anemia Mukta Bharat, Pledge for 9, 12 by 12 initiative, the portion. We're all aware, and the gap, as both the leaders have spoken, is to further our thought processes and to get on to action and implementation so that we make this dream a reality. So Shapath is one such initiative, the Path to Anemia Mukta Bharat. It's going to be largely supported by 5 NGOs who are already working in the rural India. And the MCure is one of the companies which is supporting the Anemia Conclave today, but they are also one of the key stakeholders in Shapath. So as Foxy leaders, Nandita and Rishikesh, if you have to take a Shapath, if you have to take a resolve, this is the one thing that I want to do as my bit contribution, getting rid of anemia. As you said, as both of you have said, prevention is better than cure. So the girls have to be the pink of health before they become mothers. Okay, with that vision, what is the one thing, one message that you want to give to our audience who are here to listen to newer and novel methods? Yeah.
Can I begin, Rishikesh?
Yeah.
See, I think the problem with iron that we have with which gynecologists, see, I've roamed around the whole country as the Foxy president, and what I've realized is that the patients don't have compliance. The patients give up the treatment halfway and all, because iron does have a lot of problems. Side effects, the gastrointestinal side effects, the taste, etc., all these things. So I think what we need to give them is something that will be very palatable for the patient, and I think that's so very important. And that is what we should tell our people, that please detect it and treat it in a way which the patient is comfortable, so that you can follow up. And I think
Nandita, this is a very, very important point, but because we may say 100 things, but it's a patient who has to take it. And if she's having problems, she's not going to obviously take it. So OCANET, which is actually supporting this program, that's the whole vision of bringing in the liposomal iron, which is again an oral iron, but devoid of all these side effects. So maybe that is another innovative implementation way forward. So thank you so much for that very focused input, because making things happen needs patient compliance.
Compliance is so important. Yes. We are doing everything we can.
Yes, absolutely. So it has to reach where it should. Yes. Reach in the manner that it should. Brilliant. Rishikesh.
So no, I feel that the anemia is, as we were telling, that there is one iron deficiency anemia, but there's a huge amount of hemoglobinopathies also, like sickle cell anemia, and there is thalassemia, which we need to target that also, and there is a big contribution coming from malaria and tuberculosis that also can cause anemia, and we don't know about the COVID infection. See, now unfortunately, the whole language of health is permanently changed, and every time we talk about health, COVID has to come in. So suddenly it has become a player in all our concept, all our psyche, even future implementation of all the programs of the government, because already there is a budgetary deficit that is there. How are we going to take care of our ongoing programs when all the money is being sucked out by COVID? So I personally feel that suddenly, as a president of Foxy, my vision was different. Now suddenly my vision is different. And I don't know that after 2 years, when I actually take over, what will be my vision? Will it be more to do with the nation building, or whether it will be do with Shapath? I have no idea. So we will have to think in terms of real time, because of the whole world, also the donor agencies worldwide, all of them they have no money anymore. So how do we do it? How do we now implement policy at the, because a lot of this health policy is pro bono, means we do it free of charge. So this is one area which I think we, Hema, as we talk over the next 2 years, we interact and we evolve the process. So it is has to be a real-time process. It no longer can be a planned process. It can be planned, but it is. So that's one thing which is very important to understand. And the second thing is that I believe that the way to implement a successful policy is by federalization of health. This has to be understood. Now, for example, there are 5 companies doing this. It's, every state has a different character. Every state has a different ethos. And this has to be understood by all of us. It cannot be centralized. It has to be federalized. So health implementation, even at the Foxy level, has to be federalized, not centralized. This is my new thought process.
Two important
so I'm evolving in that direction, and I feel, I must thank you also for that, because this thought I got from when we were having a discussion in the IHW Council, when we were on a forum, and I realized very much that at that point in time that if I have to really create an impact on the health policy of this country, I have to use the federal structure and I have to use the state structure and implement policy. That is the only way we can do a successful implementation of policy. If the state government is not interested in what you are doing, you can't implement policy. And you can't say that Maharashtra state has the same thought process as Orissa state. Policies are different in different states. Funders are different in different states. So, and companies also, pharma companies are different in different states. So this has to be understood, and that has to be used for future implementation.
So now that with this program support, Rishikesh, the OCANet, which is supporting this program, is also in our net. So I feel that the big takeaway from both the leaders are that they're always wanting to learn and always wanting to do more than what they have done before. And the thought process, which is ever expanding and ever flexible. Friend, those two, qualities are really be underlined and underscored in leaders whom we have presented to you today, because thinking out of the box beyond deficiency anemia, breaking the silos and thinking of collaborating into a federal structure, thinking of the patient herself who is in the middle of all this for the compliance issues. So everything adds to one step further in our resolve to move ahead. And I think with brilliant thought process and youth leaders from Foxy, who will be our feet on street soldiers to conquer, if I may say, anemia, we will no longer let it just remain as our dream, but from innovation to implementation, we will take the shapath of moving ahead along the path to the anemia Mukt Bharat. And we resolve today that we will make an impact, both professionally, personally, socially, and in a preventive manner. That is the way, those are the multiple angles through which, the lens through which we look at this issue. And both our magnanimous leaders, Dr. Palshetkar and Dr. Pai, have been here with us, which has begun this program with very positive, very inspirational thoughts. There is a lot we can do. Come on, let's get together and do it. That is the kind of spirit that they always inspire me with. And I really, really thank them on behalf of artists and OCANet, and of course the Science Integra, which has brought us together. They said that some stalwarts presenting their point of view will take the initiative by leaps and bounds forward. And we thank you once again for propelling the movement and spirit.
Hema,
which you always
I would like to say to all of you who are listening is Hema is a great thought leader, and she has always been with the Federation and her thoughts, and she is the one thread that binds so many presidents together, so the binds the Federation together. She has been the person who has been one of the ideators and the ideas to everyone get, but implementer of the Manyata program, which has become such a successful program now. Once the program is running, then anyone can run it, but to create the idea, to implement the idea, that is the challenge. So of course sustenance is very important, And in that also she is helping us. So I am really grateful to her for her leadership, and I hope that she will give it to us for 2 more decades to come. Because you women,
absolutely, as
both of
many
you
have
on guest,
commented, mine is absolutely unconditional, and I'm so thankful to your affection and your trust in the leadership, because just today I have posted that we have the courage to experiment, we have the courage to pilot, we have the courage to pioneer, because we have the courage to fail. We have the courage to wake up again from the fall and move ahead till we get to the point where we can make an impact and a meaningful difference. So thank you for constantly sustaining.
To what Rishikesh said, you've always been my role model. And today's thing was, a talk, there's nobody like you who can get out the different, thought processes of your panelists. I think that's wonderful job that you do. That's really amazing. So I really enjoy being in conversation with you, because even I learn a lot and I grow a lot looking at you and listening to you.
Thank you so much. Thanks, both of you. And I know that they have multiple things lined up for a busy Sunday that they have, but this was a delightful few minutes spent with my very beloved friends more than anything else. So thank you so very much.
Thank you.
Bye-bye.
Bye-bye. So now we have to actually move on with really achieving our resolve that India achieves 12, which means that we prepare and prevent the anemia and walk towards anemia Mukt Bharat. And your efforts will be a great contribution to let every mother enjoy their womanhood. And believing patient compliance is important, liposomal iron is here with us, promising strategy and replacement. And this thank you is for all of you who have respected invitation by Okanet and artists, and Science Integra, Subbu, patient and team for putting us face to face virtually to have this small deliberation, know how we can be impactful with what is available to us in a new and novel way. Both the leaders were talking about Manyata initiative. Manyata is just not a dream. It's just not a promise. It is a priority to ensure that every expecting mother is offered what we call the Manyata standard of care with quality, respect, and dignity. We can't allow anemia to be 20% of the times responsible for maternal deaths. Really, really strong challenges. Iron is a very strong molecule. So stubborn that it is strongly regulated. How much ever you take, only 10 to 15% of the iron is absorbed. This is so true for the food supplements that Nandita was talking about, or the WHO, the recent micronutrient supplementation, that not only iron, but folic acid and other vitamins and minerals also, which have to get into the system. But how to overcome or circumvent this problem of such poor absorption? Maybe they are taking it, but it is just not good enough. So what do we do? Diet rich in iron, that is one thought that has already been placed. But again, it is in thinking, acting and doing. So FIGO has come out with the tagline of Think Nutrition First, because we are primarily prescribing medicines. The diet, which is an important daily component, we have to guide them towards that as well. Oral iron supplements, there are so many of them competing with each other, but not having the necessary impact and improvement. Parenteral iron, gone are the days where we're using iron dextran, but the newer molecules which are safer and of a medium molecular weight, which has been also researched and found effective and safe, and sucrose and sorbitol and carboxymaltose, etc. And of course, the component transfusion is there as the last resort. And so what we must place on records is, we are not going to talk about the problems today. We know what the problem is, but we have to talk about the solution. Shortcomings of oral iron supplementation therapy. Anybody would know that second line is the parenteral, we are helplessly giving, but if there is something oral, that's what we would want to pick up first. shortcomings we know, that's how we have just said. Liposomes have been used as a very, very novel method of carrying these drugs for a better impact. And liposomal drug delivery. Package the iron in such a manner that absorption and the impact of giving oral iron becomes more effective. Can we do that with this liposomal technology? Is that a good option? Oral, yes, not working. IV, yes, it is the only thing which is, a sure shot for now. But can liposomal iron be a good option as we move forward? So what is it that we are trying to do? As you can see in the blue picture here, is something that we are trying to mask or cover. Face masks or Mask India has become a very popular, a concept in the Corona pandemic. As Rishikesh said, we can never stop talking about Corona time and again, because that is here with us to stay and intruding in every of our discussions. So iron salts like ferrous pyrophosphate covered with the liposome. It means it's like putting a burqa, a mask. The spherical structure of a phospholipidic nature that is similar to the human cell membranes. So what does this actually do? How does this act? And what are we trying to achieve by covering the iron with the liposome? This preparation escapes the gastric acid barrier. Because of this masking, it just moves away into the small intestine. What happens next? In the small intestines, there are the M cells who have very low lysosomal content. Lysosomes are the ones which will kill the iron. But when it reaches the intestines, when it has to face only the M cells, okay, what the M cells will do is it cannot do much because it is low in the lysosomal content. So without getting disturbed, the specific transporters not being needed, they just get absorbed and absorbed. So the liposomal protection allows the iron to overcome the free gastric environment. That's the first thing. Therefore, it prevents the early degradation of the substance, or it prevents its inactivation, and it moves ahead into the small intestine to get happily absorbed. And if we can ensure this with an oral iron which is masked with liposome, then that means we would have gone a long way. Again, I emphasize that liposomal protection allows the iron to overcome the free gastric environment, prevents early degradation, and gets absorbed directly. And what does this do? It's exactly the point which Nandita said. Gastric irritation, acidity, intestinal problems of constipation or diarrhea. Can you imagine that all that will be gone because it is not exposed to the iron, and iron is not going to irritate that and get into the liver directly for next job that it has to do. So the mechanisms of absorption with this liposomes are multiple. This is just a simple picture here which shows that it can get absorbed. A simple absorption also will get the iron into the system. There may be this endocytosis. These endocytes will just engulf this and get the iron inside with the liposomal capsule. There can be a fusion of the lipid. That means you see here, the blue and the yellow have exchanged. Okay, with this exchange of lipids, again the iron is getting into the system, but in a very soft way, in a way that it does not damage the gastric mucosa or the intestinal mucosa and cause all those horrible side effects. And therefore, the bioavailability is going to be very, very high. Micronization of the iron and the encapsulation of this micronized iron in the lysosome really has provided us a new opportunity for improving the tolerance with oral therapy. All the time we grumble, and we have done some baseline studies also, even like a dot therapy. Every day somebody is going home, putting the tablet into her mouth, making sure that the compliance problem is not there. Even then the iron doesn't get absorbed, only 30% of the times. Only 0.5 grams rise in hemoglobin. Why? Because you may put it into her mouth, she'll swallow it. Fluorides in the water the supari or the phytates that she takes, the kind of food that she takes alongside that, chronic intestinal infection that she may already be having, worms which are there in it. There are 1,000 things which come in the way of absorption. So we have come to think in our mind this oral iron anyway is not working. Let's now move on to the next, that is parental iron. But now we have the option of new oral iron which can bypass all this. These are nano-sized particles. The lipid bilayer provides the stability and releases the contents gradually. So here is your iron pyrophosphate. Okay. It is now tucked in nicely in the center of this liposomal capsule. So the enlarged area increases the bioavailability, the smaller particle size makes it absorb more efficiently, and because of this masking and encapsulation with the liposome, there is no side effects or minimal side effects. So what does the conventional iron do? Here is where the conventional iron gets and breaks the intestines to give all the side effects before it gets into the bloodstream. But liposomal iron, you see, this is the iron, but it is got decorated with the liposome, which is constantly protecting till it actually manages to reach the site that is the liver for further hemopoiesis through the lymphatic stream. This is the simplest way in which we can understand the difference between the conventional and the liposomal iron, as in the advantages which are already obvious. So bioavailability has to be greater. That is a given. It's now a common sense because we're seeing to it that all the way it is transported. So obviously it is 3.5 times higher and greater than the free phosphorylated iron, 0.7 times greater than the iron sulfate, and 4 times greater compared with iron gluconate. So this is phenomenal. If you can just give a simple oral tablet which can multiply and amplify the effects of this, this is how you will get the bioavailability figures. As compared to the controls, this is nearly double the amount is bioavailable. That means available for use. That is the truth. So beyond the iron needed for women, there is iron needed for very many other conditions, inclusive of bariatric surgery or cancer patients or chronic kidney disease patients. Lots and lots of other specialties are also using the iron. And what do they say about it? You will see that in bariatric surgery, whatever the researchers have done, they have assessed the effect of switching to oral liposomal iron in patients receiving IV iron supplementation after the bariatric surgery. Why? Because after the bariatric surgery, they have no option but to give parenteral iron because they have to have the iron molecule bypass the gastric milieu of the environment. Doesn't oral liposomal iron do that? We have just seen that it very well manages, and it's an excellent alternative for IV iron for maintenance treatment in bariatric surgery patients with iron deficiency. This reduces the cost, improves the quality of life. It is so easy and compliant for the patient that after bariatric surgery, if she has to undergo the torture of taking the parenteral iron time and again, this is of course a fantastic alternative. In diabetic patients with iron deficiency anemia, they are supported by liposomal iron. Median proinsulin needed appears to be lower because just like PCOS and GDM, the diabetes type 2 and the iron deficiency anemia are also in nexus. If the anemia is more, then the insulin requirement is also more. So they always strive to correct the iron deficiency anemia by a variety of means. Mostly what they give is IV sodium ferrogluconate. But if there is an option of the liposomal iron, as in the oral iron which we are just talking about, then all the diabetics can be covered with this and their insulin requirement will go lesser. Preoperative protocol, as in many studies, Sardino et al. Showed that liposomal iron was able to improve the perioperative protocol because shorter hospital stay, lower blood transfusions, faster hemoglobin recovery after surgery, and very, very low cost on a mass scale of use. Simula, in his observation study, noted that hematological ambulatory practice, the oral supplementation with the liposomal iron, effective, safe, preferred by patients, of course, to avoid the intravenous therapy. Quality of life is better. Last but not the least, the cost is also better. So when we want to implement on a mass scale, you don't need a healthcare provider to go there and give an IV and worry about the side effects and the costs, etc., or hospital admissions, or in which setting it can be done. All those are eliminated. You have to just give the tablets and that's it. Safety profile. Again, the most commonly experienced are very, very minimal. No serious side effects with liposomal iron, which is obvious with the way it is absorbed. And the common side effects of conventional iron therapies, such as the abdominal pain, nausea, constipation, discoloration of the mucus and feces, all of these are eliminated, better tolerated, and very, very few adverse effects. So patient compliance is far better. So as I said, we intend to translate these evidences into our experience. For that, we need a nationwide cooperation with all the stakeholders, inclusive of yourselves who are listening to this lecture, because when you know that this is available, don't discard the oral iron as, oh, we have used it before, it's anyway not improving, patients are not taking because they're having so many side effects. Here is the one which is new, which is available, which will fill up as how it is shown in this study and this slide. Pyrophosphate and pyrophosphate, not a simple thing. It is tucked into the liposomal capsule or the mask versus the placebo. You will see that F is the pyrophosphate ferrous, which is liposomal, which has shown a dramatic improvement in the hemoglobin compared to the placebo group, and it occurs pretty much quickly. So in another study where 30 postmenopausal women, because when we say girls and women, we mean to encompass all age groups. The girls given this oral liposomal iron before they embark into their pregnancy and their reproductive age, finish their reproduction, gone into menopause, even there the hemoglobin, because of menorrhagia, if it is less, 8 weeks of liposomal iron supplementation, and the hemoglobin rise was very, very significant, from 10 to 12.7, as you can see in one of these studies by Sacco et al. The baseline to the 8 weeks value, it's a clear demonstration of how it scales up. This is yet again a study published way back in 2015. And so what are we still doing in the year 2020? We need Corona to alert us that you're not in the pink of health, your immune system is disturbed, and you're more susceptible and vulnerable to COVID infection. Why can't then we build up a well-tolerated, least side effect oral preparation, which is so obviously convenient? And the lower dose and higher efficacy also has to be noted, because just with the minimal dose, 14 milligrams were compared to 28 milligrams. So the change in parameters were with a much lesser dose compared to the conventional iron. So low dose, cost effective, patient compliance, least adverse effects. What else are we waiting for? So 30 milligram per day is the recommended dose, 8 to 12 weeks, but in pregnancy, we'll give it throughout. The distinct features of liposomal iron are high gastrointestinal absorption, high bioavailability, very well tolerated, low incidence of side effects, no stomach upset, no constipation. Patient will improve the quality of life which she herself can perceive, and it is easy to take. So compared to the intravenous iron, which we ourselves had promoted helplessly, because we were seeing that the existing oral components did not have any great impact. So what to do? We have to get their hemoglobins up. So we were resorting to the use of intravenous iron. So the difference between the liposomal and the conventional is shown here. The phospholipid bilayer is present. Effect of gastric acidity is nil in the liposomal iron because it just bypasses and moves ahead. Oxidation of iron is a clear no-no. There is a targeted iron delivery to the lymphatic system into the liver, absorption of iron is hugely enhanced. Absorption via intestinal M cells, as I said, as lysosomes. So the liposomal iron is very well absorbed. The effect of food, therefore, doesn't matter because there is nothing to do with the gastric the mechanism, whatever happens in the stomach, because it bypasses that. No oxidative damage to the intestinal epithelium. All this explains the minimal or absent gastrointestinal effect. It has no metallic base and it does not chelate with other metals as well. So there are very many distinct differences between liposomal iron and the conventional iron, and many randomized double-blind studies. How much we can improve and how much more we can improve. Suppose like iodized salt, we give this phosphorylated iron encapsulated in a liposome, which is not broken down in the stomach, gastric juice, fruit juices, etc. Why don't we fortify the fruit juices with either micro-encapsulated iron phosphorylate, or in comparison to placebo, does it have an effect? This was a study done by Blanco et al. And they have concluded fortification of fruit juice with the micro-encapsulated and phosphorylate is indeed a very novel way ahead in mass supplementation, and we need to do the advocacy on these novel dietary fortified supplements as well. So in conclusion, I must say that non-compliance of oral iron due to GI discomfort is a given and a known fact. We are now coming up with solutions which are simpler as compared to the complex administration and the risk factor associated with parenteral iron. And whilst these persist, we are determined to make a difference with what is available to us as on today in the form of the novel liposomal technology for encapsulating the iron phosphorylate to reach the unreached. Thank you very much for your kind attention. If there are any questions from our esteemed audience, I think there are some questions in the chat box. I'm delighted to see so many hundreds of registered participants. I do hope this very simple deliberation on something which has been a continual nuisance for all our patients right across all age groups, because anemia will impact her health. And in preventive healthcare, it's really important to get our hemoglobins up. So the question from Dr. R. Annie Balasubramaniam from Bengaluru is COVID and anemia, any connections? Yes, anemia will put your entire capacity to fight infections very low. That is a known fact. So to resist COVID, to be less vulnerable to COVID-19 infection, you need your innate strength and immunity to combat the infection. And anybody who is in the pink of health will be definitely able to fight it better. This is Chetna Tanna from Mumbai. Can you tell these toxifications of liver? I really want Chetna to elaborate on this question, because I showed the entire pathway of absorption, endocytosis, and the lymphatic passage through which these reach in a packaged form to the liver, and from there onwards the process of production of the red blood cells using the iron for the heme component starts rolling in, and that is how I have understood to be the mechanism of this iron reaching its final destination. So if Chetna could again key in the question to elaborate about the detoxification, maybe if I'm wise enough, I will tell you today. Otherwise, I will definitely look it up and convey it to you through the right channels. Dr. Geeta from Dombivli, what are the points for diagnosis of nutritional anemia? See, the anemia may be due to any cause. First of all, if you do her hemoglobin and find that it is 10, let's not have the attitude of chalta hai. We have to get her hemoglobin up, that's for sure. Then we have to find out her diet plan. What is she taking? and guide her specifically for iron-rich food substances. To also give her simple know-how of what are the kind of phytates and fibers, tea and tannin, which can affect the absorption, and therefore at what times what she has to take and what she has to avoid. The commonest fourth thing is the deworming, which is given by default to all our pregnant women as well. So that has to be always kept in mind. So these are the first four basic simple things. Then to move on with, if there is any source of bleeding, constant loss of blood, and many reasons for that has to be plugged in. Chronic intestinal inflammation and infection is another thing which prevents the absorption. So nutritionally, you make sure that she's taking the right things. Till she's not improving, then you have to apply your mind as to what is the root cause of anemia. These are such simple and doable things. But again, dear friends, we are not paying enough attention to this because we are so used to getting, unless it's like 6 or 7 and we really have to do something about it, we don't. But even 9 or 10 are in suboptimal health. So we need to pay attention to that as well. Again, Dr. Balasubramaniam asks, does the present pandemic have any bearing on iron absorption and utilization? One of the many things that we don't know about COVID-19 infection, we will have to place this answer rather ambiguous, because in a large section of patients who have tested COVID positive, who may be symptomatic or asymptomatic, what is the state of their iron absorption and iron utilization? Unless we have evidence on the table, we cannot respond to this question in an arbitrary or an ad hoc way. If the iron content can be enhanced through diet and the supplements, that will be the need in these cases. Bipray Kumar Saha from Calcutta asks, Dextrose lipo syrup recommended in which age group in case of neonates? Again, Dextrose is from Okanet. It is available both in the form of syrup and capsule. And very, very typically, the infancy and childhood, the syrup or the suspension is the preferred method from the age of 1 year or so. But more importantly, Dr. Bipray, the main issue, the first 1,000 days of a child's life is to correct mother's anemia in the first place in the early and mid trimester of her pregnancy, because there is a strong clinical evidence and data today that as a knee-jerk reaction just to save mother's life, if you're giving IV sucrose, IV FCM, etc., when she's about to deliver, it does not help the fetus. 30 weeks is the peak transfer from the mother to the fetus, and the brain development, the cognitive behavior of the child, everything is impacted. So in the Anemia Mukta Bharat, the guidelines which have been laid down by the government in 2018 speak only of parental iron the third trimester and parental iron when severe anemia is detected late. We are now embarking on a large study which says that give these things, but give it in the before the mid-pregnancy, because it will help not only the short-term goals of tiding over the crisis in labor, but it also helps the long-term for the fetus, the unknown neonatal impact, neurological, which is there. So it definitely, we as OBGYNs have to start thinking it all begins in utero. So the mothers have to be protected. Then when it comes to the infants, then give the suspension and all, exclusive breastfeeding for 6 months. That is what we are promoting. Within 1 year, the child will start eating a few more things. Then you can always give the Dextrose lipo syrup, as you've said. Then Vijay Lakshmi Patak from Dibrugarh asks, what is the dose of adolescent girls liposomal iron? It's 30 milligram per day, which is a very safe and a very effective dose. Okay, so there's also a comment saying that iron liposome has the superiority of the liposome that can cross the duodenum through the membrane fusion, membrane diffusion, or phagocytosis. So do we need to avoid any food particles or any other preparations along with this iron? Are you suggesting that we will have lesser side effect. This is Dr. Parul Shah from Ahmedabad, and we don't have to add fiber with the liposomal iron. Very, very important and interesting points that Dr. Parul Shah from Ahmedabad has made. The company name is OakNet, okay, not OkaNet. We are South Indians, so for everything we will add the tha and the a in a very different manner. What is the diversity in India? For apple, we say apple in Kannada, or the table like that. You know, add the Vinita to Vinitha. That is also so the language and the pronunciations, as how it has been brought to my notice. It's also a barrier, because you're trying to tell something to the patients in terms of diet, in terms of what can clash with the absorption, etc. But she's not understanding, because it's also a barrier of the language. So we need many pictures, this, that. So as OakNet has said, that yes, there is least interference. So all those issues which I brought up with dietary iron not being absorbed because of this, that, and the other, if you ignore all that and give her one tablet of the liposome technology of the iron pyrophosphate, all those things, I said this, that, and the other may interfere with the absorption, that is eliminated. And then surely the bioavailability of this is more by all the 4 mechanisms of absorption and adsorption that we have just said, and therefore the efficacy will be maintained with the least number of side effects. Okay, so this is a comment by one of our champions from Foxy, Dr. H. Bagade, who has said that this is a new product for the gynecologists, and I have always been laying my thoughts on this menace of anemia. 2007, our work started. I said, this is so simple. We know what the problem is. We know what to do, but we are not able to make any impact. The same percentages of anemia, very proudly we declare on all the international forums, oh, India has got so much incidence of anemia, oh, so many mothers are dying after PPH, because if their anemia was controlled in or before pregnancy, we would have saved those lives. Come on. Now it is time to speak about solutions and not about problems. Let us definitely take the tapat or the resolve for ourselves. Each one should resolve that they should make their practice anemia free. In the first line, nutrition first. Given that, make sure she takes liposome iron, which is a new novel oral. You should not have second thoughts about giving that, because that is by far the best available oral preparation, more bioavailable, less side effects. Wait and see whether we are getting ahead with any difference. I knew it was Dr. Deepak Bagade. It was originally written as Dr. BH in capital Agade. So I was fondly hoping it is our own beloved Deepak Bagade who may be listening to this lecture. He has heard me speak on anemia n number of times. Still, he has spent his Sunday morning listening to this. I'm so very thankful to you, Deepak ji, and the kind of support and inspiration that you give me is not known to you, because all the time you've been so encouraging for so many sometimes crazy initiatives that I take, and I'm always inspired by the support given by you. From Patna, Sadanand Kumar asks, can liposomal iron tablet, beta-cause lipo, be given in BD dose for pregnant women? Certainly, because when the 14 milligram, 28 milligram, these are the two doses which have been tried out in many studies, and compared to the 60 milligram of elemental iron that we will require with the conventional tablets, because the bioavailability and absorption is so dismal, even 30 milligram dose will pull up the hemoglobin. And given the fact that so many of our patients are really very low in hemoglobin, they will benefit by a 30 milligram BD dose. Even if you give 30 milligram OD, the level of hemoglobin with an oral It's a remarkable improvement compared to the other oral preparations that we were using ever before. So if there is a public health issue, if there is a cost constraint, and 2 times the patient is not being able to take the tablet, one she takes iron, one she takes calcium, some vitamin D supplements, this, that, and the other, if only once, then twice the number of women can be treated at half the cost. That is also one way of looking at it when we are doing on a mass public health. At least, golito de do. That is the kind of campaign that we need to do. Something is better than nothing. 30 milligram BD dose is quite appropriate for most of our pregnant women because their hemoglobin will build up and their iron stores will also build up. And pregnancy is the one and only chance for us to interact with our patients. Adolescents will not come to us, and menopause, well after they get into trouble, they come. There are no defined policies or incentives for the patients as well. It's very, very crucial for us. Encash on the moment of pregnancy and they check up to have the handle on them to get moving with whatever best we can do to them. So, yeah, BD dosage, very well tolerated in any case. And if a hemoglobin improves, then maintenance you can give only 1 per day. That most likely that she will require for a long time. Thank you for all the corrections that have been brought in, including I may not know exactly the pronunciation of POCA, net. I know that liposomal iron is here to stay and it will slowly and steadily change the face of adolescents and the young girls in India also because of the ease of administration and the compliance. And when they move on to the reproductive age and embark on a pregnancy, our dream is that they should already be in the peak of their health. So with that, Dr. Lewis, does liposomal and how was it able to improve the perioperative protocol allowing a shorter hospital stay? I can definitely send you that study, which is by Simon et al. Because in the West, always they will look at the minimal length of hospital stay. So if the hemoglobin is quickly built up prior to admission, for example, and we don't have to retain her in the hospital to give the intravenous iron, and we can minimize or even not even have the hospital stay only for the purpose of giving alternate days iron sucrose, for example, to build up the hemoglobin post-delivery, post-operative. You can just send her with the oral iron prescription, therefore her hospital stay is less, and the improvement is by default to be expected. This is how the details given in that study, but I can definitely send that to you. And now liposomal iron is occupying since 2015. There has been a lot of buzz about it, and we are constantly looking for something better, something more. So Parag Biniwale et al. And our center, artists, that is the Asian Research and Training Institute for Skill Transfer, always at this problem of the iron, because we're not happy just doing little things and saying that now we have solved the problem, because we've not solved the problem. We need to make our practice anemia free. Each and every patient coming to us should have a hemoglobin of 12. That should be our aim. If 50% of our patients are not having that, that means we've not done enough. So we are constantly exploring newer and newer molecules which are safer and easy to take, and this seems to be the new kid on the block for us. But if it is soon picked up by many practitioners and we see the face of anemia changing, then we will have a strong belief that this is the way forward. If so, it can be preferred to over IV therapy in case. Yes, because this is Ninda Ghosh asks about ambulatory. That's exactly what I referred to in the perioperative lesson stay also, because obviously giving an oral supplement does not require any hospitalization. And intravenous therapy, all said and done, if you have nothing better, then we convince everybody that out of the preparations, this is not like the and dextran the interferons and the jectofers, which were available long back, which caused anaphylaxis and even led to death of some women who came there for a prophylactic treatment. So that scare we had to pull the people out of and convince them that if at all you want to make sure this iron reaches and has any impact, then intravenous iron is the only way. That was what was in the interim period with the intravenous iron sucrose. Then we changed it to FCM, ferric carboxymaltose, because intravenous iron sucrose requires alternate days, 5 injections in most of the patients who are moderately or severely anemic. Then we shifted to 1 dose of 1000 milligrams of FCM, so that in one go you are making sure that she has the adequate dose. If the oral preparation can work as well, the question is, why not? So constant exploration is going on. So please work your mind to an individualized manner. If the patient is anyway in the hospital and you want to give her the IV drugs, there are a group of them which are safe and efficacious. Certainly, it is not that the moment we get something new, we have to discard the old. There is a place for everything, for everyone, because anemia looks to be the problem for everyone, including the healthcare providers and the healthcare consumers. So that is what it is. Srinivas from Bangalore asks, what are the prospects of this iron replacing ferrous sulfate under the National Prophylaxis Program? It is for us to raise our voices. We need a lot more evidence on the table. The Indian data in many centers, if we can give this and get data on the table, we will certainly, in the technical advisory group in the Ministry of Health, every time I'm questioned about the data which needs to be placed on the table. And that is how a simple initiative of doing intravenous iron sucrose studies in rural Karnataka, I took the data to the table, and then it moved ahead from there and got approved. So this also will have to follow the similar format. And the moment we as a professional organizations and a group of professionals bring some evidence to the table, definitely the government is very, very open to take, because after a long time, if you have noticed, only IFA tablets were given, but now calcium and vitamin D supplements also. We said, why are you not giving it to our women? And that's also got into the policy. So it is our advocacy, how much and how loudly, and how consistently and how persistently we make noise. That will stand the test of time. Of course, with the data on the table, there's a very good chance this will be taken up in the National Prophylaxis Program. As of now, the existing programs are also paying attention to the nutrition, to the education, to the gender inequity, to sanitation, good food, good air. Everything is getting combined and clustered into a mega national movement, because all these components are important for the way forward. So that is the way we are thinking, in a wholesome and a holistic manner. But together, we will be able to make a difference. I have a firm belief in our own people. So with that, I'm very, very delighted to get a message from Subbu and team from Science Integra, who says, Madam, you've spoken enough. Now it is time for action. So you can close this delightful discussion and let everybody have their food for thoughts on the new and novel use of iron pyrophosphate, masked or encapsulated with the liposomal technology, to make the iron available to do its job where it is needed. Thanks to each and every one of you. It has been a delightful morning for me. Yet again, deliberate on something which I'm very distressed about and very passionate about, to disseminate the information about anemia and anemia care as many times as possible. Thank you very much. Namaskar.